So our next speaker is Rick Wolthusen, who will be presenting on global local paradigm in mental health from Afar to our Doorsteps. Rick did his medical training at the Technical University in Dresden, where he graduated in 2017. He then came to the US and went to the Harvard Kennedy School, where he got a master's degree in public policy, and then joined Duke as a psychiatry resident in July 2020, where he's on the physician scientist track. Rick is a leader and manages non-governmental organizations to advance the infrastructure and public perception of mental health care in Germany, the US, and sub-Saharan countries. And he has over 10 years of experience in this area. He founded an award-winning NGO called On the Move. He has numerous awards, and I just want to highlight two here for you. The first is the Order of Merit of the Federal Government of Germany, which is the highest tribute that the Federal Republic of Germany can pay to an individual to service to that nation. He also was the 2022 recipient of the Society of Biological Psychiatry Humanitarian Award. Really amazing achievements. So with that, I will turn it over to Rick.
Thank you, Dr. Posner, and thank you for the opportunity to present. I am going to talk a little bit about the work in the global mental health space I've been doing. And I'm actually reserving some of the actual work I've been doing to the very end of this presentation. And I thought, I really would start with just setting up the stage, because the work I do is not necessarily intuitive to a lot of, researchers in a lot of countries and environments, and I just hope to give you a little bit of an insight into why I chose to do the work I do, and then also present some concrete examples. So with that being said, when we always think about global mental health, I think people immediately jump to this idea of exotic cultures, going abroad, right? This the helping reflex, we need to tell other countries of how best to do mental health policy stuff, and this is not what global mental health is really about, right? The global mental health really has nothing to do with the geographic location, but the global mental health really has to do with the idea of mental health disorders are really prevalent around the world, right? It's a global issue. It's a pandemic at this point, right? And so you see, no matter where you are, no matter what continent you're on, mental health disorders are pretty significant, right? And really contribute to the disease burden and to the global burden years with lived disability. And this is really where the global idea comes from. And what's really interesting is that a few years ago, the Lancet Commission on Global Mental Health said that none of the countries is actually really doing a great job when it comes to mental health, right? So they basically say all the countries can be considered as developing countries in the context of mental health. And so yes, the US may have more psychiatrists per capita or per 100,000. Here you see the number of psychiatrists per 100,000 by WHO region. But the reality is that many parts of the US look like countries in Ghana and Kenya, right? Like North Carolina, for example, the majority of the counties doesn't have a psychiatrist, and even fewer counties have a child and adolescent psychiatrist. So that's basically what we're facing, for example, what I'm experiencing in countries like Ghana and Kenya where I work. And in a way, right, so then North Carolina and the US looks like Ghana and Kenya. So why would we treat it any differently? The US has spent a lot of money on mental health conditions, right? And building the workforce and whatnot. And yet the treatment gap, for example, for depression, again, this is by WHO region, and you see there are differences in the treatment gap. But, even in the Americas, if you take out the South American region and only look at the North American region, the treatment gap for depression is still 48%, right? So that's flipping a coin. And the treatment gap is basically the people who need medical care minus the number of people who receive evidence-based care. And the argument here is just with all the workforce we have, right, and with all the money we spend, we are still really doing poorly compared to what we could do when it comes to mental health care and access to mental health care. And so this is really where this idea of global, local paradigm comes in, acknowledging that a lot of the issues are happening on a global scale, right? And that we can actually learn what has been done elsewhere and take it, for example, to the US, like to Duke University, to Durham, to North Carolina, and see how we can apply it here, right, to provide access, equitable care, or access to historically underserved populations, and vice versa, right? Like that we can take what's happening here, like also to other contexts, right? Like, but there's really this bidirectionality. Like right now, what it really is in the developmental space is this idea of like, what can high income countries teach low and middle income countries? But really, I think the shift needs to be, right, there needs to be bidirectionality, that there needs to be reciprocity. And so this is what the global local paradigm is really about. I did want to spend a few minutes on what are some of these things we can learn, right? Like this all sounds very good, maybe, but like what are some of the things we can really learn from the global space? And so, first of all, there is this idea of task sharing and task shifting. And so task sharing is really the idea of like, when we think about the workforce, there may be a few psychiatrists, there may be a few psychologists, but the number of psychiatrists or psychologists or the demand for mental health disorders really outnumbers the number of psychologists or psychiatrists. So in a sense, right, you're sharing the task. So not only psychiatrists or psychologists could offer certain services, but you also empower other people who are not psychiatrists or psychologists to do the same job, right? So you're sharing the task. Task shifting on the other side is really the idea of like, there is just no psychiatrist, right? Like, again, like we see this in countries like Sierra Leone and many countries on the African continent. We see this in Asian countries, but we also see this in North Carolina, right? There are a lot of counties that don't have a psychiatrist. So then we need to shift the task, right? So what would be done by a psychiatrist in a setting which has a psychiatrist, right? Someone else needs to do the job if there is no psychiatrist or if there is no psychologist. And I just want to give you like a few examples of what task sharing looks like in the global space, but also like here in the US. So there's this really famous example about task sharing. It's called the friendship bench. It goes back to the early 2000s. It's many studies have been done about this. It's a study from Zimbabwe where people in the HIV clinic didn't come back, right, for medication prescription, for labs. Right, they were lost. There was a lot of like, because they took medication sometimes and sometimes not, there was a lot of resistance developing. And they figured out it's, well, because they have comorbid depression, right, which kind of prevents them from coming to the clinic. And what really happened here is there was just a few psychologists, but they couldn't meet the demand of the community members who needed help with, people with depression and anxiety. And so they took grandmothers, elderly women from the community, trained them in like delivering the active ingredients of psychotherapy, and so in this case, behavioral activation. And they showed that these grandmothers can offer psychotherapy equally effective as psychologists can in 4 to 6 weeks. The depressive symptoms went down, the HIV medication uptake rate went up, people did come more often to the clinic, right? And so it's this idea of like, you don't need a psychologist to deliver a mental health intervention. It has been shown again and again that this can be done, for example, by community members who are trained and supervised. It has been actually taken up in the US, this idea of the friendship bench. That's an example from Florida, from New York, but it also has been done in Florida. But there are other projects like the Confess project in the US. The idea is, for example, for Black male patients who, there are many reasons why they may not access mental health care. And so what this project does, the Confess project, is training barbers to talk about mental health conditions. And when they talk about mental health with the Black male community members, right, there's a lot of trust because they have been seeing the barber for many years, right? They talk about life. And then if someone screens positive or like kind of like says something, then they could refer like to a mental health professional if needed, or they can like do some, again, because they also have been trained in some baseline psychotherapy approaches and they get supervision, right? They can offer the initial help. So that's like really two ideas of like how task sharing is done in the US. The idea of task shifting is really done. Remember, like there is just no psychiatrist or no psychologist. Here's an example from Kenya. There are community health volunteers. They go literally from household to household. They screen for conditions such as HIV, TB, malaria, childhood diseases, pregnancy, right? And now these are the people who are also well positioned to screen for things like depression, anxiety, substance use, suicides, and all these types of things. And then one way it has, the idea of task shifting has been somewhat implemented in the US is this idea of collaborative care, right? There may not be a psychiatrist in many counties in North Carolina, but there are primary care physicians who can offer some of the care in lieu of a psychiatrist. But also this is an idea of like kind of a step care approach, right? So not everyone needs to see a psychiatrist. If it's like a bread and butter depression case, right? Does this person need to see a psychiatrist? Can they see a primary care physician first? So there are like certain steps people can take before they see a psychiatrist. And so the idea of collaborative care is kind of both. It's like task shifting, but it's also like a step care approach. And then when I really talk about, and this is the, kind of like the final slide of like setting up the stage is, about some of these things, like if we do, how we should do them in the US, like people's natural, there's like two issues always. Like one is about liability, right? Like it's a lot about liability. Like if we empower community members, or like include community members, who's liable if something goes wrong? That's one of the questions. And then the other question is really about, we don't know if this is effective. Well, the reality is we do know. And I'm not going to like comment on like the different papers, but while I'm talking, I'm just showing you there's a lot of papers from Kenya, Mozambique, right? Like common factors in psychological treatment showing that what we need to do and what is effective, right? So the idea of like, we don't know what we need to do in like under-resourced settings is just like, I think it's just wrong. I think we just like, we may choose to not read certain literature, but it's out there. Hundreds of papers are out there and tell us what we need to do. So now I want to just like, give you some examples of my work and how I actually use some of these ideas and principles. So first of all, I've been working with the APA and the American Association for Psychiatric Residency Program Directors on thinking more about how to integrate global mental health curricula in residency education, right? And so the research behind this is really to say, okay, let's have a pre-assessment and a needs assessment, right? And then let's have a post-assessment, like, before implementing a global mental health curriculum and after doing it. So what are the needs and how do we do this, right? Not every program like thinks about global mental health in a similar vein, right? Like some of them may be more interested in the advocacy aspect of it. Some may be more interested in the educational aspect of it. Some may be more interested in like the policy aspect of it. And so really helping programs to understand, why this matters and like how this can be done, right? Because the idea of like, the ECGME said psychiatrists in the US, I mean, the goal is to train psychiatrists like so that they are clinically doing a great job. But the reality is that psychiatrists always, also need this like public health perspective, right? And like, again, like global mental health doesn't necessarily mean to send people abroad, but global mental health also means to like look at what has been done elsewhere and integrating it into local structures to improve access to equitable mental health care. And so this is really like one of the research questions I've been working on here in the US. Another one, which I'm working on in Ghana and Kenya, is the idea of task sharing, and particularly around how can religious leaders and faith healers work with mental health professionals. So what we have been doing in Ghana and Kenya is we have this long-standing collaboration between religious leaders and mental health professionals. And we're really using this collaboration to do screenings for mental health conditions in the congregation. So every Sunday when people come to church, we screen in for mental health conditions. Either the religious leaders do it themselves or the mental health professionals do this, right? And then people get referred up if they need additional help. Like obviously they get referred for diagnosing and for treatment. But then again, some of the treatments such as like talking therapy, like 4 to 6 weeks of behavioral activation and these kind of things, they can be done in the actual church setting. We don't need to necessarily to send people to the hospital, which may be less accessible, right? It's an issue of transport, of money. It's an issue of stigma, right? So they can be treated in the community where people are. And so what we really have been working on is this idea of like, how can we leverage this partnership and how do we screen it? We have collected screening data and we are currently analyzing the screening data. We're looking like how many people who pop up positive are actually getting diagnosed with a mental health condition, how many people actually who get referred to access mental health care services in the long term, right? Because remember, our goal is to reduce the treatment gap. So what success really looks like is if we could reduce the treatment gap by finding people where they are in the community and kind of treating them early, right? Like we don't wait for them to really deteriorate and have like a condition where people needs to be admitted to the hospital, but we really just like want to find them early and treat them where they are. I'm currently doing a scoping review about catatonia in low and middle income countries. With the idea of like, you know, if you don't have ECT, for example, how else would you treat it, right? Or if you don't have benzodiazepines, which sounds like, you know, there are a lot of places actually out there which don't have benzodiazepines, which we know is our gold standard, right? But then we are doing a scoping review and just like looking at how do they diagnose and how do they treat and what can we learn about this potentially in the United States, right? In under resourced settings. Part of my research is about localized policy making and implementation. So, you know, instead of like just saying, well, here's like what suicide prevention looks like in the US, let's do this like in Ghana and Kenya as well. We actually did research on risk factors, on protective factors, on the magnitude of suicides in Kenya, in different counties in Kenya. And we found that the risk factors we have here in the US doesn't necessarily translate one-to-one to the Kenyan context, right? So we couldn't just say, well, let's do what we do here in the US and let's do the same in Kenya. But it's really the idea of like, how do we like work with community members in an integrated approach and design policies from a bottom-up level, which can then inform national policies, right? So Kenya has 47 counties. If you just do like localized policy making often enough, like in a certain number of counties, let's just say like maybe in 20 counties, then these counties, the research from these counties can really inform the national policies, the federal policies, rather than a national policy which is adapted from a high income country, right? Like trying to trickle it down to county level. We're doing it the opposite way. And so we're doing research with this, if what we call localized policymaking can be equally effective or even more effective to provide culturally appropriate care. And then like a lot of like what I'm doing has to do with like, you know, thinking about, as I said before, the reciprocity in learning, right? Like it's not just what can the US teach low and middle income countries, or what we can learn here, and then working with NIMH, with a work group at NIMH around this question. It's really the idea, right? I'm writing currently a paper about how some of these principles from the global mental health space can help us to overcome the mental health workforce shortage here in the US, like, right, when we think outside of the box and think beyond psychiatrists and mid-level providers and psychologists and social workers, and we think about the mental health workforce and really thinking about how can we integrate community members, right, more in the mental health care spectrum. So these are all like types of research questions which I'm really working on right now. Very happy to go into more details during the Q&A session, but I just wanted to give you a general sense of the mindset of my work and some of the projects I've been working on. So with that being said, I hand it back to Dr. Posner, and thank you so much.